Dietitians here at the Odette Cancer Centre. So just a reminder, the meeting today is being recorded, so that's starting now. And I'm just going to be talking about some of the different pathways that we use for delivering nutrition care here at the Odette Cancer Centre. So to start off, Happy Nutrition Month, everyone. I know we also share this month with some other professions, but really I'm here for a couple of reasons today. First of all, to shamelessly promote my profession. Number two is to kind of fill everyone in on some of the changes that have been happening with nutrition care here at Odette. I know there's been lots of changes over the last few years. Some you're aware of, some you maybe are not. So I want to share that with you and a little bit about a vision of where we're going from clinical nutrition. And thirdly, too, I'm also open to hearing what everyone else has to say about how nutrition care is happening here at Odette. If you've seen some different opportunities for nutrition care that we're not aware of or we're taking advantage of, or if there's different opportunities that you think dietitians can support the care that you're providing. So in terms of disclosures, I've been working within the patient education role here at Odette since December of last year, and funding for this position has largely been provided in part by Abbott Nutrition Canada. And our learning objectives for today, besides just sharing about some of the changes that have been going on here at Odette, I also want to talk a little bit more about nutrition care within oncology specifically. So thinking about high, moderate, and low nutrition risk patients, what's the difference between standard and specialized nutrition care, and again, looking at opportunities to improve the nutrition care that we provide within our current care models. So besides myself, we have 6 other dietitians working here at Odette. You may have seen our posters hanging up in some clinic spaces. And within the team, we're really divided out, each taking responsibility for some different disease sites. And as you can see, 3 of our dietitians specifically are dedicated to the head and neck site group, which should tell you something about these patients. And then a little bit about myself, because my role is a little bit different. I've been working at Sunnybrook for the last 8 years. I started on the inpatient side in surgical oncology and the burns ICU before moving over to Odette, where I did some one-on-one counseling. I was responsible for the lung, esophageal, GU, and melanoma patients. And then, like I said earlier, for the past 15 months, I've been working within the patient education role. And we've been very lucky with our funding from Abbott. They've been really supportive of all kind of interventions we've been working on. And really the mandate of this work is to assist in projects that are going to prevent malnutrition and promote adequate nutrition intake through education. So currently in my role, I'm not doing any one-on-one counseling with patients. But in the last 15 months, looking back on the work that I've done, it's been guided a lot by clinicians and by patients. And some of the themes that have emerged from this work are creating resources to address patient and clinical challenges. And we'll talk a lot about those resources today, what we have available. Engaging the multidisciplinary team as partners in delivering nutrition care. And finally, engaging with patients and clinicians to address a desire for nutrition information. So besides learning about nutrition care in the oncology setting, I think you're going to see these 3 themes kind of weave throughout the presentation. So a little bit of background and a little bit of learning about oncology nutrition. Hopefully this is familiar to a lot of people, but otherwise just a good review. So there's lots of benefits to good nutrition. Whenever I'm doing educations with patients, though, I make it very clear that nutrition cannot cure their cancer. The role of nutrition is to support patients in staying strong so they can complete recommended treatment. And when we see the benefits of good nutrition during cancer treatment, we see just that. Patients are making it to more of their scheduled treatments. They're having less side effects. They're having fewer infections. They're able to maintain their weight. We're seeing delays in disease progression, as well as improved chances of survival and improved quality of life. And the benefits of nutrition persist throughout the entire cancer experience. Early post-treatment, we're seeing people recover and get better faster, have a better chance of survival, and a better quality of life with less symptoms. 5 years after a diagnosis, we're seeing less late side effects from treatment, reduced risk of cancer recurrence, and decreased healthcare costs if they're able to maintain that good nutrition. So what does good nutrition look like? I want to keep this really simple. And at the core, good nutrition is adequate calories to maintain our weight, adequate protein to repair damaged cells and maintain muscle mass, and adequate liquids to support regular body function. So when people aren't able to meet these three text boxes, this is when we become concerned about malnutrition. And malnutrition is a state of either deficiency, excess, or imbalance of energy, protein, and other nutrients that, importantly, it causes adverse effects. And we see those adverse effects set in pretty early. As soon as patients lose 5% or more of their body weight, we see it as a strong predictor of reduced response to oncology treatment, reduced survival, and reduced quality of life. And if we're being really specific, it's not necessarily weight that's the predictor, but it's decreased muscle mass. And muscle mass is likely a better indicator of nutrition status than weight. However, muscle mass is harder for us to measure, whereas weight is a readily available measurement that we can easily do. So within the healthy population, we see about 15% of people have low muscle mass. At time of cancer diagnosis within the oncology population, low muscle mass can be as prevalent as 50% of the patients we're seeing. It has lots of negative outcomes like poor performance status, a sooner toxicity to chemotherapy, shorter tumor survival, and reduced overall survival. And this reduced overall survival is even within the context of preserved body weight. So just the muscle mass we're talking about. And on the right-hand side here, I have a link to a video from the Prado lab. And I love this because it really just illustrates why low muscle mass is an invisible problem. From the outside, both of these people look very similar. They probably have a very similar weight, but we can see that their muscle composition is very different. And it's that low muscle mass that's going to lead to worse outcomes and lower resilience during treatment. I also like to remind people that I think we all tend to have that a lot of us tend to have a bias, whether we think about it or not, that weight loss at any body size, no matter what BMI, is an indicator that there may be malnutrition going on. Sorry. So no matter someone's body size, if we think they're overweight, we still want to let the dietitians know if we're seeing weight loss, because that's likely an indicator that they're losing muscle mass, not just adipose tissue. So the best thing is to prevent loss of lean muscle mass. And if that's not possible, we also have the opportunity to treat it. So we already talked about calories and protein. And the third piece of this equation is exercise. And I bring up exercise, first of all, because it's actually part of the nutrition clinical practice guidelines. And also secondly, we don't have as many people advocating for just exercise. We have 7 of us advocating for nutrition and even less advocating for exercise. So I think this just highlights how this is really important for all of us to be a part of this. There's lots of benefits to exercise. Unfortunately, we don't have as many resources to promote exercise here at the Odette Cancer Centre, but I do want to make people aware that there is lots of great resources available through Wellspring. Wellspring, they offer prehab classes for people waiting for OR, which I know our breast cancer group is big users of already. They also offer virtual and in-person exercise classes. These sessions are 2 sessions per week for a total of 12 weeks. And it's not a one-size-fits-all approach here. Patients are offered individualized exercise plans, and all this is free. So definitely a great opportunity if your patients are asking about exercise. So back to malnutrition. Not every cancer patient is malnourished, but every patient with cancer is at risk of malnutrition. And our rates of malnutrition are really widely vary. Depending on the disease site and the type of treatment, it can vary anywhere between 7 and 94% prevalence of malnutrition, with a lot of people presenting with malnutrition at time of diagnosis. So this widespread isn't really helpful for us as dietitians figuring out who needs our care and services. So a lot of the time we'll kind of classify big groups of people as high, moderate, or low nutrition risk. So in this high nutrition risk category, a lot of these people are presenting with malnutrition at time of diagnosis because of cancer or tumor burden, and this tends to get worse over the course of their treatment. So these groups are usually easy to think about. There are esophageal and our head and neck with an almost 80% prevalence of malnutrition, as well as our pancreatic and gastric cancer patients. Our moderate nutrition risk people, this is really like a high mix of people, and the reasons why they develop malnutrition really vary. A lot of the time, they are related to symptoms that evolve because of their treatment, but some of these people have pre-existing malnutrition because of their cancer or their tumor. And within this group, we have our gynae patients, and we can even see within the subset here, while a quarter of the general gynae population has malnutrition, prevalence is up to 70% within the ovarian subset. We also have moderate prevalence within the colorectal, hematology, lung, and CNS groups. And finally, we have our low nutrition risk patients. And generally, as a rule of thumb, as dietitians, we're not super worried about malnutrition within this group. When we see malnutrition, a lot of the times it's related to advanced cancer, and in some cases, the treatment that they're on. It's also hard to find data on prevalence of malnutrition in these groups because it's pretty low. So we have melanoma, breast, and GU. And actually within the breast and the prostate cancer patients, specifically the ones on hormone therapy, we actually see not so much malnutrition, but weight gain within the first year of their diagnosis. And while we're not concerned that this weight gain is going to lead them to missing treatment sessions, we are concerned that in the long run, it can have negative health impacts. So the final concept that I wanted to introduce was this difference between standard nutrition care. And this is the minimum level of nutrition care that should be delivered to all patients, regardless of their nutrition status. So really everyone that walks through the door here at Odette, whereas specialized nutrition care involves a comprehensive nutrition assessment and individualized nutrition care plan to maintain or improve a patient's nutritional status. So whenever a patient is malnourished, they need specialized nutrition care. And really, as dietitians, that's what we're trained to do, the specialized nutrition care. So we're going to talk about how we use specialized nutrition care with our high-risk cancer patients. So within our clinical practice guidelines, one of the first recommendations is that we detect changes in nutrition status early and regularly evaluate nutritional intake. So I'm going to talk specifically about the process that we use in our head and neck and esophageal disease sites, because this is something that we've been able to alter over the last few years and have found a lot of success with our current format in supporting patients and supporting as well and integrating ourselves as part of the multidisciplinary team and delivering nutrition care for these high-risk patients. So first of all, we're identifying these patients either through physician referrals or hand screening, looking at our clinic lists. And because we know prevalence of malnutrition in this group is so high, it's really worth our time to look at these lists because most of these people are going to have malnutrition. So the quicker we can pick it up and the quicker we can intervene, the better. We're doing nutritional assessments on these people. We're asking about what they're eating, what texture of food they're eating, weight, are they having any symptoms that are impacting their nutritional intake, and have they noticed any difference to their functional capacity, or do they have any physical signs of malnutrition? The second part of this suggestion of this recommendation is regularly reevaluating. And we've had a lot of success here integrating ourselves into the multidisciplinary team, being part of weekly radiation review. And we found this to be really helpful in monitoring our patients that are on active treatment because it kind of acts as like a mini interprofessional rounds. We're able to make decisions about nutrition care in the moment in collaboration with the nurses and with the doctor and implement those plans right away. We're doing follow-up in other ways too. We're doing phone calls. This became increasingly popular during COVID. Our patients like it a lot. We're seeing people in follow-up clinics. And as a newer way, we're seeing people in virtual care clinics. As dietitians, we love this. We find it to be a really effective use of our time. It has a really high acceptance by our patients. And also too, because we're supported by the virtual clinic coordinators, we haven't really run into any issues with tech. Patients are able to log on either via Zoom or phone call without issue. And we've also been doing these virtual clinics kind of in two formats. Most of these clinics are just the dietitian with our own patient list that we see. We also have one of our clinicians that's doing it in collaboration with the physician. And again, it's really another opportunity for us to be multidisciplinary and solve nutrition problems in the moment. The third part of delivering the specialized nutrition care that isn't part of our practice guidelines, but is really important for us, is signing off on patients or caseload management. There's 6 of us. There's way too many patients for us to be seeing every single one and be following them indefinitely. So when we go to sign on a patient, we're looking to see that their nutrition status is improving. It might not be perfect. They might not be back to pre-treatment levels, but they're eating more. Their weight has either stabilized or they're gaining weight, and their symptoms are improving. We also want to make sure that they have the adequate tools to self-manage their nutrition. And they're aware that if there's any changes in their nutrition status, that they should re-refer themselves to us so we can reevaluate. And when we're offering the specialized nutrition care, our first plan of attack is always trying to optimize oral intake. And this is where I've been able to do some work within my current role. So if afterwards you want to go back to these slides, if you click on all of these, they've hyperlinked to Chrome extensions where you can find some of the handouts that we use with our patients. I highlighted these ones specifically because we use them with our head and neck and esophageal cancer patients all the time. When we're optimizing oral intake, we're making sure patients are getting adequate protein. We're addressing any symptoms that they may have with their head and neck population. A lot of the time it's dysphagia or discomfort swallowing hard foods. This third one here, drink to your health. Feel free, everyone, to steal this bit of advice. But the first bit of advice that we give to almost anyone who's struggling to eat enough, is to switch their calorie-free liquids like water to liquids that contain calories and protein. So we're thinking things like milk, soup, oral nutrition supplements, because there's this kind of misnomer that only water is hydrating. All liquids are hydrating, so why not get them to do double duty? Hydrate them and use them to help achieve your nutrition goals. We also have a popular handout called Smoothies and Shakes that teaches people how to make high calorie, high protein drinks at home. And from interactions with our patients, I've been able to develop this new resource called How to Make Nutritious Soups. And it mirrors the smoothies and shakes handout, but we're finding that it has better acceptance within some groups because there are some groups of people for cultural reasons that aren't interested in eating cold foods while they are undergoing treatment. So this is kind of a warm food alternative, or just an alternative that's great in the winter when we're all seeking those warmer foods. The other tool we have at our disposal is oral nutrition supplements. And this is really just more of an information sharing with everyone. So when you send a patient down to us to ask about oral nutrition supplements, what we're going to do is we're going to do a nutrition assessment for them. We're going to evaluate what their nutrition needs are. And if possible, we're going to give them some free samples of some supplements so that they can figure out what their taste preference is. We don't have capacity to support people with nutrition supplements during their entire treatment. And really our samples are just to get them pointed in the right direction. We also have a resource that goes through kind of the different types of oral nutrition supplements if someone is looking to figure out what supplement they should be taking on their own. We also have the option sometimes to write prescriptions for nutrition supplements. And again, this isn't everyone does not qualify for a prescription, but really what we're looking for is that this is a patient's sole source of nutrition. So prescriptions aren't intended for someone who's drinking 1 or 2 bottles of Ensure a day to supplement their intake. This is primarily where they're getting their nutrition from. And also that they either have esophageal dysfunction, dysphagia, or maldigestion or malabsorption. So we need them to meet these criteria in order to fill out the nutrition products form that goes with the prescription. And even still, after we find out the prescription, we need to make sure that they are provided with coverage. So in my time working as a dietitian, I've never seen a private drug company that has covered the cost of oral nutrition supplements, but it is covered through the Ontario formulary. So if they're over the age of 65 or on ODB and they meet all these other criteria, then usually we can get a prescription for them. When we fail to meet patients' nutrition requirements orally through mouth, that's when we start looking towards nutrition support or tube feeding. So kind of the 2 criteria that the guidelines lay out for tube feeding is, like I said, inadequate oral intake despite other interventions, or if we expect that radiation is going to induce severe mucositis or obstructive tumors for our head and neck cancer patients. Additionally, two practical things that we think about is also, are the patient or caregiver going to be able to manage this G-tube at home? And is the patient agreeable to this intervention? In practical terms, the process that we have here at Odette is we have 2 appointments a week, one from IR and one from GI, that's dedicated to inserting G-tubes in our outpatient head and neck cancer patients. These patients return to us the next day where we provide them with G-tube education, and this is a collaborative process. Nursing is generally responsible for doing a G-tube check and making sure that they know how to care for the stoma site, whereas dietitians are responsible for showing them how to use their G-tube and what to put through it. So also within my role, I've been able to update our booklet called Feeding Through the Gastrostomy Tube. The dietitians provide this booklet to anyone with a feeding tube when we do our education. And it reviews not only best practices, but also Sunnybrook specific practices for G-tube care, and also goes over a lot of practical tools and tips for managing a G-tube at home. So if you're a clinician and you have questions about G-tubes and the information is not within like the Sunnybrook policy, this would also be a good place to check specifically for kind of that practical piece of information. So that's the specialized care that the dietitians do. Next, we're going to talk about those moderate nutrition risk patients and this idea of standard nutrition care. So our practice guidelines say that all patients in an outpatient cancer center should undergo malnutrition screening. And for the sake of transparency, we're not doing great at this right now. We're doing some limited nutrition screening. Our new GI cancer patients are all screened using the Canadian Nutrition Screening Tool, which asks about weight and oral intake. We talked about how we're doing some more hand screening of our head and neck and esophageal cancer patients. Otherwise, we're reliant on referrals from clinicians and from patients to identify patients that may be at risk of malnutrition and would benefit from a dietitian intervention. And just so that everyone is aware, dietitians don't require a physician order to assess a patient. So whatever your role is, you're welcome to refer a patient to us. And then we'll loop in the physicians as needed to keep them updated on this patient's nutrition progress. Some barriers to universal malnutrition screening that we've identified is that our population is just really big. There's no way we could hand or manually screen all these people. That wouldn't be an effective use of our time, and that's consistent with some other big outpatient oncology programs in our area. And then number 2, we're lacking the appropriate digital infrastructure to support virtual self-screening. So this ideally is where we want to go, and we're seeing a lot of potential opportunities with the new health information system. But in our current state, we know this is a deficit in our program, so it really makes standard nutrition care, an important part of our process. And I'll just go over what that standard care is next. So if you remember, standard care is the minimum level of nutrition care everyone should be delivering. Every patient should be receiving. And the problem is there's so many patients and not enough dietitians that we on our own can't provide all the standard nutrition care. So Erickson and his colleagues are really advocating as nurses being a pivotal part in providing the standard nutrition care. And I want to extend that even further and say everyone on the multidisciplinary team. And particularly we say nurses because nurses are often the first point of contact with patients and they're considered a trusted caregiver. Nurses are also generally responsible for coordinating comprehensive care, so they know what's going on with the patient. When we talk about standard care, things that we're talking about are early detection of nutrition concerns. So those obvious things, weight loss, decreased oral intake. It can also just be any kind of side effect that may affect oral intake down the road. So obviously things like mucositis, low appetite, fatigue, pain, constipation, all those things have the potential to impact nutrition at some point. And we know early intervention and nursing providing information on symptom management is one way that we can mitigate some of this risk. Another part of that standard nutrition care is the coordination of dietitian consult or the escalation of that nutrition care when we think that standard nutrition care is no longer cutting it. Standard nutrition care is also supporting the implementation of nutrition care plans. So during our regular interventions, it's asking about oral intake, encouraging oral intake, creating a supportive environment for tube feeding or even eating by mouth. Particularly comes to mind our patients that are here for those really long days, for their like chemo radiation days, making sure we give them an opportunity to eat and a space to do so. It's encouraging the proper use of medications to manage symptoms. And it's also alerting dietitians if our nutrition care plans aren't working or aren't effective. We try our best, but sometimes we need to implement some different strategies in order to address people's malnutrition. And the third part is educating patients to understand how adequate nutrition affects their well-being and treatment success. I think sometimes our oncology patients just think it's a granted that they're going to lose weight during treatment, and we don't want them going in there with that mindset. We want to provide them with the information that if they do the work to prevent weight loss now, they're going to benefit from it down the road. And for our patients, they benefit from the multidisciplinary team cooperating and working together, because this way they're more likely to get consistent messaging around nutrition, which we'll see is a bigger problem. And also we're able to do kind of a holistic consideration of all the patients' problems, not just their nutrition problems, because we know our cancer patients can be complex. So as a dietitian, my role is, again, promoting all these things that we do in terms of standard nutrition care, but it's also acting as a support to enable high quality standard nutrition care. So within my role, some of the things that I've been doing is working on resources that support standard nutrition care. And these two examples were things that nurses actually identified that with access to adequate resources, they felt confident delivering this level of nutrition information. So our chemo nurses said that with this resource, diet tips for low blood cell count, they felt confident delivering this information to patients. And then different nursing from different site groups also identified that having a handout about taste and smell changes would enable them to provide that information confidently to patients. And I totally agree. Unless these symptoms are causing a patient to lose weight, this is well within the scope of standard nutrition care and kind of those symptom prevention interventions that we know nurses are great at. I've also had different members of the care team come to me looking for the development of written resources that could support them in providing interaction, that could support them when providing nutrition information to patients. And these resources were things that didn't exist before or they didn't have access to. So the first example of this was radiation therapist coming to me because there was a lot of different information coming to prostate cancer patients about how to manage rectal gas during their treatment. So together we're working on doing a literature to review to see what best practices in this area, and then also working to develop education materials for clinicians. So we're all on the same page, giving out the same information, and then integrating this information into patient resources. Nursing also approached me because they felt like the written resources they had for managing constipation were not adequate for reinforcing the education that they were giving. So in collaboration with nursing, pharmacy, and physicians, we're in the process of developing a new written resource that gives practical information on diet, lifestyle, and pharmacological interventions for managing constipation, with the idea being that this will be a written resources that reinforces the verbal education that nurses are giving all the time about constipation. And this last one was kind of an easy win for me. So GI and gynae nurses identified that they needed some resources about low fiber, bowel obstruction, new and high output ileostomies for when they're supporting their patients. These resources all existed within the clinical nutrition space. So really all I had to do was update these, make sure that the information was relevant, and then work on dissemination. So all these resources currently are or will shortly be available on Library World for frontline staff to use in their education of patients. And a big goal of mine in this role has been trying to get the right resources into the right hands. So all the things that we talked about are available throughout the center. You can find them in some clinic spaces. This picture here shows some of the nutrition resources available on the back wall between A and B clinic and D and E clinic. We also have them on, we're working on getting them into radiation and chemotherapy. We have them on our inpatient oncology units. And when in doubt, if you can't find what you're looking for, everything is available on Library World. And there's a few objectives for this. Number one, I want to make sure that clinicians have the resources they need to address low and moderate nutrition risk patients in the moment. Not everything needs a dietitian consult. So it's great if that can be addressed while you're seeing them. Also, clinicians have identified that having a print resource generally makes the patient interaction smoother and more satisfying. And finally, even for our patients that do need specialized nutrition care from a dietitian, giving them a resource while they're waiting to see us is great. A lot of the time they can implement some of these easier interventions in the moment. And then as dietitians, we can come in and do the comprehensive assessment and do some more of that nitty-gritty work that needs to be done. I've also been doing in-services with different groups and getting a lot of positive feedback. And what I'm really encouraged by seeing is that after these in-services, nurses were saying that they felt more confident answering patient nutrition questions, and they knew where to direct patients to find accurate nutrition information. And these are really important parts of providing standard nutrition care. Finally, when we're talking about our low nutrition risk patients, these are the patients that don't really have a lot of nutrition issues, but an emerging trend that we're finding as dietitians is these are kind of our like information-seeking patients. They just have a lot of questions that need to be addressed. And I think across healthcare in general, we're seeing this rise of nutrition misinformation. The rise of misinformation, and specifically in nutrition, we're encountering it a lot. So just so we're on the same page, when we're talking about misinformation, we're talking about information that is false, inaccurate, or misleading according to the best available evidence at the time. This is like an evolving area of study, so it's hard to get decisive information. But this study found that cancer was the most investigated health issue on social media. And why we care about misinformation is there is the potential for some negative consequences. So the most severe consequence that we're concerned about is the potential for harm. And again, anecdotally, we'll say this is something that as dietitians are seeing a lot more of. Patients coming into our office that really have like no symptoms that should affect their oral intake, but they've been hearing so much misleading information from family, friends, the internet, social media, that they've made huge changes to their diet and are actually restricting their diet much more than they need to, which is leading to unintentional weight loss. And even if they're not having any symptoms in the moment, it puts them at higher risk for malnutrition down the road if they do eventually develop symptoms. Some other consequences of misinformation we're hearing is the potential deterioration in trust in valid science. Patients are finding it distressing to try to tell the difference between accurate information and misinformation. It's having a negative effect on their well-being. And as it stands currently, the burden for identifying misinformation falls disproportionately on patients and families. Nutrition is a very young and a very rapidly evolving field. So even us as health professionals often have times discriminating between information that's credible on social media. So it's really hard for our patients to be doing this, as well as dealing with all the other factors involved in their treatment. So where are patients getting their information? All over the place. 60% are coming from the internet. Who they're getting it from, again, is all over the place. As health professionals, I think we need to be concerned that this study found that only 12% were getting information from doctors. 5% were finding their information online from registered dietitians, which, for me, it doesn't feel great since we're supposed to be the experts in this area. And then 1% were getting their health information from other healthcare professionals. 22% were getting it from government professionals or academic sources, and almost 60% were getting it from other sources that had no identifiable nutrition qualifications from a tertiary education. So who knows if that information is credible or not. And I think this really highlights, particularly here at the Odette Cancer Centre, when patients are getting their information from different health professionals, that working together, we have the potential to reach a larger audience So being consistent with their nutrition information can really only benefit patients. So when I looked into what patients wanted to learn about nutrition and how they wanted to get this information back in 2023, there was some common threads. Patients wanted to learn things about like what's the relationship between food and cancer, how about eating well during cancer treatment, how can I prevent cancer from coming back. They wanted to learn a little bit about how to find credible information online and a little bit about symptom management. This was consistent with another study that I found. And this study, I think, also had a really interesting part because it had a qualitative portion where they went into focus groups and they found the following themes came up, which I think really like illuminated the mindset of a lot of our patients. So patients found that there was a distinct lack of nutrition guidance. There was way too much nutrition misinformation. They felt one size did not fit all in terms of receiving nutrition education. And they preferred to get their nutrition education from dietitians. When we talked about the format, they were really all over the place. Some people wanted it in live online sessions, some people wanted one-on-one personalized advice, and other people wanted to read it off a web page. So, while there's consistency in what patients are looking for, how they want to receive the information is kind of every which way. So this creates, a lot of opportunities, but also, a really big challenge about how we're going to meet patients' learning needs. So again, just throwing a little bit of education in here. For all these low nutrition risk patients, our message is actually very simple to them. And this is a message that I think all members of the care team can be for providing. So if patients do not have any nutrition problems, their weight is stable, they're not having any symptoms, we want them to be eating a balanced diet. Canada's Food Guide is a great place to start. We want them to be doing regular physical activity. And most important, I think what patients are asking about the most is that there's no single food that will cure their cancer or cause their cancer to grow faster. As dietitians, we are not gatekeeping any nutrition secrets. It's really just old-fashioned, balanced eating and moving your body that's going to help you do best during your cancer treatment. In terms of practical ways of getting this information out to patients, I've had the privilege of pairing with patient education to do 2 webinars in the Florence Winberg education series, where I kind of broadly talked about the nutrition before, during, and after cancer diagnosis. Both of these events in 2024 and again in February of this year, we had over 500 people register for each of these Zoom events and about 325 attend. So I think this shows that there's an obvious appetite for nutrition information and patients are eager to get it from health professionals when they can. Patients were largely satisfied with the information that they received. And when we go into specific feedback, these webinars, I think, highlighted a lot of the things that we're hearing in the broader research. So this first comment was, this webinar addressed some of both myself and my wife's concerns about my rapid weight loss, and we'll be reaching out to a nutritional specialist for assistance. Great, this patient was able to identify themselves that they'd lost weight, that they're at high nutrition risk, and they needed some specialized nutrition care. During the Q&A in particular, many of the myths around certain foods causing cancer were dispelled, which also led to reducing some of my stress. Wonderful. So we know that patients are distressed by all this nutrition information, and if we're able to provide it to them in a way that meets their learning needs, it seems like this does help reduce that stress and that mental load. She was very informative and gave us lots of areas to further investigate and showed us how to do so. And I will say this is a big part of all the patient-facing education that I do, is we know patients are always going to go home, they're going to Google, they're going to look for more information. So if we can direct them to credible sources, then at least when they're doing their decision-making about their care at home, we know that they're using good information to make these decisions off of. And finally, I was impressed at how quickly after receiving my treatment schedule, I received an email to join the session. I felt supported. I'm going to be honest, this was kind of fluky that this person received their treatment schedule and then our invite, seeing as we're only doing it once a year. But this really highlighted the need for us that we need to be doing this type of outreach like more frequently. So we've just launched bi-weekly virtual nutrition classes. The audience is very similar to the webinar. We're looking for those low nutrition risk patients that just have like a lot of questions about nutrition. We're talking about a lot of general topics, good nutrition, where to find resources if you're having trouble with your nutrition, some commonly asked questions, how to find trustworthy nutrition information online. And the benefits that we're seeing from this is in this kind of classroom format, I'm able to go more in depth with learning on common nutrition topics. I always include an opportunity for questions and answers because most of the time I cover like 90% of people's questions in my regular presentation, but they usually have one-off kind of specific questions they want asked. So we're able to do that. This class is open to patients and caregivers because we know not every patient is solely responsible for the food that they eat. We're supported by the virtual clinic coordinators, which is wonderful. We're also finding that this is a really efficient use of dietitian resources. Because most people have the same question, in a 1-hour session, I'm able to address up to 15 patients' learning needs versus when we're doing one-on-one sessions and we're only able to see like one person in 1 hour. And the final benefit that we're hoping to get from these is that the opportunity to have learners and students observe. So I've already had a couple social work students sit in on a class, and I think this also helps move forward our goal of, providing consistent information to our patients. So we're all giving the same message to them, and we're reducing that misinformation or confusion about nutrition information. I've only had 2 people give me feedback, so take this with a grain of salt. But the feedback from here has been positive that patients understand the information, the class met their learning needs, and they know where to find more nutrition information after the class. So because patients want their information in every way conceivable, we're also working on written resources. And I just want to kind of highlight 2 resources here that are specifically for this low nutrition risk population. Are commonly asked questions. So these are the patients that are asking like, can I eat red meat? Can I eat dairy? Can I eat soy? Can I eat sugar? Should I go keto? All the answers in there are in this resource, and it also points them to more trustworthy resources if they're going to keep Googling things at home. How to eat well after cancer diagnosis goes over healthy and mindful eating, meal planning, exercise. And if you remember all the way back to the start of our presentation, those breast and prostate cancer patients are at risk for weight gain after they start treatment. So it addresses weight gain during cancer treatment and really encourages adapting different healthy behaviors to help, protect yourself long term. And because that kind of healthy eating wellness advice usually we need multiple interactions with the patient over a prolonged period of time to work on those kind of goals. We're not always able to do that as the dietitians here at Odette, just because we have pressure from other high nutrition risk groups that need our support. So within this handout, there's lots of links to community resources where patients can receive that ongoing support and hopefully feel supported throughout their entire cancer experience. And finally, our website. So if you have questions, you want to look a little bit more in depth at anything we talked about today, a lot of this information is available on our website. We're always working on updating it, but right now, if you go on there, you can find information about when you should be seeing a dietitian, how to connect with a dietitian, how to sign up for our virtual nutrition classes, a lot of those handouts that I talked about, and where you can find other trustworthy information. So that's kind of where we're at right now. As we're looking forward, there's always lots to be left to do. So we're looking for opportunities to better integrate dietitian services and nutrition care into our current models. So if you see an opportunity in your practice that you think would really benefit from a dietitian being a part of, please let us know. If you have come across a clinical problem that you think a nutrition resource could help solve, again, please let us know. We're looking for opportunities to support all clinicians in providing that standard nutrition care. We haven't given up on universal malnutrition screening. We're going to keep working towards this. And then finally, we really want to increase access to evidence-based nutrition information. So if you are missing a nutrition resource in a certain area that you think would be really helpful, let us know. We're always working to update our online presence. We're looking at, is there an opportunity for classes for different groups of people? And as clinicians, if you just think that within your group, or your practice site, having a little bit more nutrition education would be helpful in a certain topic, again, let me know. We're happy to explore all those things with you. Okay. So that is all for me today. So thank you everyone so much for your attention. And again, too, I'm happy to take any questions that you might have if you want to drop them in the chat box here. I'll be online for the next few minutes. Okay, great. There's a long question here, so I'm just going to read through it and then I'll summarize it for the group. Okay, great. So this is from one of our radiation therapists. And again, I know I said a lot like nursing, 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 but yes, absolutely, radiation therapists are so important for doing that standard nutrition care because you guys are seeing the patients literally every day. So I think we gave that example of the gas and radiation as something that came from that group around symptom management. And I'm just going to read this a little bit more in depth to make sure I answer it more fully. Yeah, so in terms of encouraging patients to follow their specialized nutrition care, is a patient's specialized nutrition care plan easily accessible? Yes. We do all of our charting within SunnyCare. And normally at the dietitian's notes at the very bottom of the note, if you're going to read anything, read the bottom of it. It will have our assessment of the patient, so what we think the problem is, and also our plan for the patient. So if that's doing tube feed, if that's incorporating more high calorie, high protein foods, if that's taking an oral nutrition supplement, all that information is available there. And patients should also know what their nutrition care plan is. So just asking them, are you having any issues with nutrition? Are you having trouble following the dietitian's advice? All of that can be really helpful in making sure that patients are following their specialized nutrition care plan. And again, too, like anyone as part of the care team, we love it if you just talk about nutrition, bring it up so that patients are keeping it top of mind. Yeah, so then there was another comment here saying radiation therapy does have a symptom screening tool. Perhaps you can integrate the malnutrition tool there. Absolutely. So ESAS, again, I think there's a lot of work happening center-wide to get more of our patients screened that way. And in the past, we've kind of looked at different opportunities to tag malnutrition screening onto ESAS to see if we can kind of buddy them up. So we are still working on that to see if there's an opportunity there. Ideally, though, we want to be using a validated malnutrition screening tool to be doing that. So we're working on it. We're trying. But definitely just for any clinician, if you just keep in mind kind of like the two questions, are you losing weight? Are you eating less than usual? If they say yes to either of those, then those are a good sign that they're probably at high risk for malnutrition. But for, functional ways, we are looking at other opportunities to tag it onto screening that's already happening. So I know some of our other clinics are kind of going full throttle on the ESAS screening. So we're looking at opportunities to tack on there. And then definitely also with the new HIS. And then, yeah, I'd be happy to connect more with some of our radiation therapists to see if there's an opportunity to integrate that more into your workflow as well. But definitely, hopefully something that we're asking about a weekly radiation review too. Okay, that's all the questions that are in there right now. So thank you so much, everyone, for participating. Keep sending questions through. I'll be on for like the next few minutes. But again, too, if you have any thoughts or any ideas about future opportunities, a need for nutrition resources within your area of practice, please shoot me an email or walk over to patient and family support. And I would be happy to connect with you because I will say like a lot of our projects that I'm coming around to are really, nutrition issues that we didn't know existed until a clinician or a patient brought it to our attention. And then we're really happy to look for solutions to those things together. So thank you everyone so much for your time. Oh, great. I have one more question too. This is about the variety of different nutrition cultures and resources for different cultural diets. Um, yes, this is definitely a struggle within creating any kind of nutrition education is to try to capture everyone's food practices and not have 20 different versions of a resource. So definitely within the work that I've been doing in the last 15 months, that has been a grounding part of it to try to have different cultures represented in the food examples that we give on our resources. We're working on it. I'm also working on um, seeing if other resources already exist that are more specific to different cultural backgrounds. So hopefully building up a bank of those that we can point people towards. And then again, an ongoing thing, but a very expensive thing is making resources available in other languages. So that is something that our patient education department in general is always thinking about and seeing where we can move more towards that. So yeah, definitely keeping different cultural traditions back of mind or front of mind when we're creating these resources. And if you see, specifically have an idea about a food that works well, or a really distinct cultural diet, like just connect with one of us dietitians, let us know. And we'll see if there's an opportunity to integrate that into some of our written resources as well. Okay, perfect. Okay, I think that's it for questions now, but thank you everyone so much for attending. And again, please feel free to reach out if you have any other comments after the presentation is complete, if you think of something.